Welcome. Today we're diving into the three phases of wound healing, really focusing on the key cellular and molecular bits relevant for surgical practice and, of course, for those board exams.
Absolutely. Getting these phases straight is fundamental. It impacts how you manage patients, predict outcomes, handle complications. So let's start with phase one, the inflammatory phase. Usually the first, 6 days or so?
Right, days 1 to 6, it kicks off almost instantly, doesn't it, with vasoconstriction.
Yeah, a really brief vasoconstriction.
Hmm.
But then pretty quickly you get vasodilation and increased vascular permeability. That's driven by things like histamine, serotonin, and nitric oxide. Opens the gates, really.
And that sets the stage for the coagulation cascade, forming that fibrin clot.
Exactly. And that clot isn't just a plug. It's packed with growth factors, initiating the whole repair process. Plus, it provides a scaffold.
Okay, so the stage is set. What actually calls the cells into the wound? What's the signal?
That's chemotaxis. It's triggered by a mix of signals, stuff released from platelets, complement factors like C5a, bits of broken down tissue, and, any bacterial products if there's contamination. They're like homing beacons.
Got it. So the signals are out. How did the cells physically get from the bloodstream into the tissue?
It's a neat process. First, leukocytes stick to the vessel walls, that's margination. Then they squeeze through the gaps, diapetesis, and they use that fibrin matrix we just mentioned to navigate through the tissue.
Let's talk about the specific cells showing up during inflammation. There's a sequence, right?
Definitely a sequence.
Hmm.
First responders are the neutrophils. They're usually there within 24, maybe 48 hours.
And their job is mainly inflammation and phagocytosis, cleaning up debris.
Pretty much. Initial cleanup crew. But here's a key point, especially for exams. Neutrophils aren't actually essential for wound healing to happen successfully.
Ah, okay. That's important. So who is essential?
The macrophages, they start becoming dominant around 48 to 96 hours, maybe day 2 to 4, and they are absolutely critical. They're the real directors of the show, releasing tons of growth factors that drive everything that comes next. You really need to grasp their importance.
Okay, macrophages are key. And then lymphocytes, they come in a bit later.
Yeah, lymphocytes show up around day 5 to 7. Their role in this early phase is, well, less clearly defined, possibly involved in modulating collagenase, maybe some ECM remodeling later on, but it's not as central as the macrophages.
Right. Okay, that covers the inflammatory phase. Let's move into the next one, the fibroproliferative phase. That's what, day 4 up to about week 3?
Yeah, roughly. And the name gives it away. Fibroplasia, proliferation, it's all about building the new tissue. Three big things happening here. Matrix formation, angiogenesis, and epithelialization.
Let's start with the matrix. Fibroblasts are the key players here.
Absolutely. They start migrating in around day 2 or 3, but they really take over and become the dominant cell type by about day 7. And they just churn out collagen. That synthesis ramps up significantly from day 5 and keeps going strong for several weeks.
Is it just collagen, or are other matrix components being laid down too?
Good point. You also get glycosaminoglycans, JAGs. There's a sequence to their appearance, too. Hyaluronic acid comes first, then others like chondroitin 4-sulfate, dermatan sulfate, heparin sulfate. They help provide structure and hydration.
And this is when the wound starts to actually get stronger.
Yes, exactly. You start seeing measurable tensile strength around day 4 or 5, right as that new collagen starts being deposited.
Okay, second major event, angiogenesis.
Yeah.
New blood vessel formation.
Crucial. You need new blood vessels sprouting from existing ones, that's angiogenesis, to bring oxygen and nutrients to all these busy cells. VEGF and nitric oxide are major drivers here.
And you distinguish that from vasculogenesis.
Right. Vasculogenesis is forming vessels from scratch, de novo. That's more of an embryonic thing, less common in typical adult wound healing. Angiogenesis is the main process here.
And the third part of this phase, epithelialization, covering the surface.
Yeah, sealing the deal. It involves epithelial cells at the edges, mobilizing. They lose their contact inhibition, flatten out, and kind of crawl across the wound bed over that newly formed granulation tissue.
How do they move?
They break down their connections, use integrins differently, and just migrate until they meet cells coming from the other side. Then contact inhibition kicks back in, and they stop migrating horizontally.
And then they multiply.
Exactly. Basal cells behind the migrating front start dividing mitosis to build up the cell numbers. Then they differentiate vertically to restore all the layers of the epidermis. It's about restoring that barrier function.
Okay, so after fibroproliferation, we enter the final phase, maturation and remodeling. This can go on for a long time, right? Week 3 up to a year.
Or even longer in some cases, yeah. The key thing here is that the frantic building phase is over. Around week 3 to 5, you reach an equilibrium. Collagen synthesis roughly equals collagen breakdown, so the amount of collagen doesn't change much anymore.
But the quality changes.
Precisely. The collagen that's there gets reorganized, it becomes more ordered, and stronger cross-links form between the molecules. This is what continues to increase the wound's tensile strength, even though the total collagen isn't increasing.
And there's that important shift in collagen types, too.
Yes, very important. During the proliferative phase, you lay down a lot of type 3 collagen. In remodeling, this gets gradually replaced by type I collagen. You're aiming to get back towards that normal tissue ratio, which is about 4.1 type I to type 3.
What else changes in the scar during this phase?
It generally becomes less cellular. The gags and water content decrease, making the scar less swollen. Vascularity also decreases, so a mature scar looks paler than a fresh one.
And the final strength. Does it ever get back to 100%?
No, unfortunately not. Peak tensile strength usually hits around 60 days, maybe a bit longer. And even then, it's typically only about 80% of the original unwounded tissue strength. That's about as good as it gets.
Since collagen is so central, maybe a quick refresher on its basic structure and types?
Sure, structurally, it's that classic triple helix, 3 polypeptide chains wound together, rich in specific amino acids, hydroxyproline and hydroxylysine, which are important for its stability.
And the main types relevant here?
Well, type I is the most abundant overall skin, bone, tendon. It's the main structural collagen. Type 2 is mostly in cartilage and cornea. Type 3, as we said, is important in early wound healing, also found in vessel walls, bowel, uterus. Type 4 is different. It forms networks in basement membranes. That shift from 3 back to I is really key for mature scar strength.
We mentioned growth factors driving things earlier. Can we quickly list the big ones and their main jobs?
Okay, quick rundown. FGF, fibroblast growth factor, stimulates fibroblasts and keratinocytes, pulls fibroblasts in. VEGF, vascular endothelial growth factor, main driver for angiogenesis, stimulates endothelial cells. TGF-beta, transforming growth factor beta, big role in fibroblast migration and proliferation, also involved in matrix deposition.
And PDGF and EGF.
Right. PDGF, platelet-derived growth factor, stimulates fibroblasts, endothelial cells, smooth muscle cells, and EGF, epidermal growth factor key for keratinocyte division and migration during epithelialization, also affects fibroblasts. They all work together in a complex network.
Let's touch on contraction, especially important for wounds left to heal open, right? Secondary intention.
Very important. This is driven by specialized cells called myofibroblasts. They're basically fibroblasts that have developed contractile machinery like smooth muscle cells and strong adhesion points.
When do they appear and do their work?
They pop up around day 3. Their activity really peaks between day 10 and 21, pulling the wound edges together. Then, as contraction finishes, they tend to disappear through apoptosis.
Does the amount of contraction vary?
Yes, it's inversely related to the amount of dermis. Thicker skin, like on the back, contracts less than thinner skin, like on the eyelids or looser areas.
Okay, let's quickly define the types of wound closure we talk about clinically.
Sure. Primary healing, or primary intention, is when you close the wound directly, sutures, staples, whatever, immediate approximation.
That's secondary.
Secondary healing, or secondary intention, is letting the wound heal on its own. It fills with granulation tissue, contracts, and epithelializes over time. Think of pressure sores or large defects you can't close primarily.
And the third type?
Delayed primary healing, sometimes called tertiary intention. That's when you initially debride the wound, leave it open for a few days, maybe because of contamination risk, and then close it primarily once it looks clean and healthy.
Right. Now, a big topic. Factors that mess with healing. There are quite a few. Let's start with genetics and intrinsic factors.
Yeah, genetics can predispose people to abnormal scarring, like hypertrophic scars or keloids. Also, rare genetic conditions affecting collagen or elastic fibers like Ehlers-Danlos or cutis laxa obviously impact healing, though fixing the wound doesn't fix the underlying genetic issue.
And just normal variations, skin type, age.
Definitely. Skin characteristics,
Yeah.
its thickness, elasticity, even location on the body affect how it heals. And yeah, healing generally slows down with age.
What about systemic health problems?
Big impact. Things like diabetes, significant atherosclerotic disease affecting blood flow, renal failure, any kind of immunodeficiency, even malnutrition. They all put the brakes on healing. The body just doesn't have the resources or optimal conditions.
Vitamins often come up. Which ones are actually important?
Vitamin C is critical essential for collagen synthesis. Deficiency, scurvy, classically presents with poor wound healing. Vitamin A seems to help reverse the negative effects of steroids on healing.
What about vitamin E and zinc?
Vitamin E is an antioxidant, but Taking really large doses might actually inhibit healing, so more isn't always better. Zinc is a cofactor for lots of enzymes involved in repair, but again, supplementation really only helps if you're actually deficient. Routine supplementation isn't generally recommended without deficiency.
Drugs. Which ones are common culprits?
Smoking is a big one. Nicotine causes vasoconstriction, carbon monoxide reduces oxygen carrying capacity, hydrogen cyanide messes with cellular metabolism. It's bad news all around for healing.
Steroids.
Steroids are potent anti-inflammatories, which sounds good, but they also inhibit epithelialization and collagen production, generally slowing things down.
Chemotherapy. Anti-inflammatories.
Anti-neoplastic agents, chemo, generally don't have a huge impact if they're given, say, more than a week or two after the wound is closed, but timing matters. Other anti-inflammatories like NSAIDs, there's some theoretical concern they might reduce collagen synthesis, but the clinical impact is debated. And then you have specific drugs like lathyrogens, D-penicillamine, which directly interfere with collagen cross-linking, leading to weaker scars.
Okay, shifting to local factors right at the wound site. Oxygen seems key.
Absolutely critical. Healing is an energy-intensive process, needs oxygen. Anything reducing delivery, atherosclerosis, vasospastic conditions like Raynaud's, scleroderma, poor cardiac output will impair healing. Hyperbaric oxygen therapy is sometimes used to try and boost oxygen levels in problem wounds.
Infection.
Major barrier. Bacteria compete for oxygen, lower the pH, produce enzymes like collagenase that break down tissue, and just generally keep the inflammatory process ramped up inappropriately. You have to control infection for healing to proceed.
What about chronic wounds specifically?
They often get stuck in that inflammatory phase, partly because there's an overabundance of proteases, particularly matrix metalloproteases, MMPs, that constantly degrade the new matrix. That's one reason why debridement, removing that unhealthy tissue and bacterial burden, can help restart the healing process in chronic wounds.
Radiation therapy.
Radiation causes long-term damage. It harms blood vessels, reducing perfusion, and directly impairs fibroblast function, making tissues heal poorly, often years after the treatment.
And simple things, moisture, temperature.
Yeah, keeping a wound moist generally helps epithelialization cells migrate better in a moist environment, and warmth helps maintain good perfusion. So appropriate dressings are important. Oh, and excessive free radicals can also be damaging.
Finally, let's talk about the different types of scars we see.
Okay, hypertrophic scars are raised and red, but they stay within the original boundaries of the wound. Often have more type 3 collagen, tend to occur in areas of skin tension. They might improve over time or with treatment.
And keloids.
Keloids are different. They grow beyond the original wound borders. They can be quite large, itchy, or painful. Histologically, they have really thick, disorganized collagen bundles, both type I and 3. There's a clear genetic link, more common in certain skin types, and they're notoriously difficult to treat high recurrence rates. Usually need multiple approaches like silicone, steroid injections, maybe even surgery, plus radiation.
What causes a scar to just look wide?
That's usually just mechanical tension pulling the scar apart as it heals, especially if the closure is perpendicular to tension lines. Not really abnormal biology, just physics.
You mentioned fetal healing briefly. Is scarless healing possible?
There's evidence that early in gestation, fetal skin can heal without a scar. The environment is different. Lower oxygen, higher hyaluronic acid, different inflammatory response, different collagen ratios. It's a big area of research trying to figure out how to replicate that in adults.
And managing scars once they've formed. What actually works?
Silicone sheeting or gel, used early and consistently, seems to be the most evidence-based option for improving hypertrophic scar appearance, though the exact mechanism isn't fully clear. Corticosteroid injections, as we said, can help flatten hypertrophic and keloid scars, but carry risks like skin atrophy or hypopigmentation.
What about things like pressure garments or massage?
The evidence for pressure therapy and massage is pretty weak, honestly, and things like topical vitamin E or onion extract products. Really no good evidence they provide significant benefit beyond just moisturizing.
So, quite a journey through the phases and factors. It really underscores how interconnected everything is.
Absolutely. From the initial clot to the final collagen cross-linking, it's a continuous process, and so many things can influence it, positively or negatively.
Understanding these details, the cells, the signals, the timings, the potential pitfalls is just crucial for surgical planning, technique, and managing patients effectively post-op, especially thinking about those exam scenarios.
Definitely. So perhaps a final thought for you to consider. How might a deeper grasp of these molecular events, say the specific roles of different growth factors or matrix components, lead to new therapies for wounds that currently heal poorly?
Good question. Something to think about. Thanks for joining this deep dive.